بدأنا بأول محاضرتين عن الكاردياك سيتي ايميجينج، وبعدين الثلاث محاضرات اللي فاتوا كانوا عن الكونجينيتال. هننتقل للجزء الأخير for our session cardiac MRI imaging. الدكتورة شيماء صلاح زميلة الكفاح في الكارديوفاسكولار ايميجينج جروب معانا هتكلمنا على an introduction to cardiovascular MRI imaging.
Good afternoon. I'm Shaima, Salah, lecturer at Radiology Department at Shams University. Thanks for the organizing committee for giving me this opportunity. Thanks for the organizing committee for giving me this opportunity. Today I'm talking about the cardiovascular MRI, introduction to the MRI. Cardiac magnetic resonance imaging is established modality for both anatomical and functional assessment for the cardiovascular diseases. It allows also evaluation extracardiac structure within the thorax or even upper abdomen. Its advantages: non-ionizing radiation with high spatial resolution, easy reproducible, so it can be used in the follow-up of the patient with no radiation. To perform a cardiac MRI, we have first to know it's a multi-stage process. We have to know the proper indication, what's the clinical question the doctor is looking for in order to prepare the patient, have the exam planning and scan acquisition accordingly to have a record that fulfill the needs of the patient and the doctor. Okay, from the indications, it can be used in non-ischemic cardiomyopathy, ischemic heart diseases, in heart failure patients, valvular heart disease, congenital heart diseases, myocarditis, intracardiac masses, and pericardial diseases. First, we will start what are the imaging plans. The heart is not in the same direction as the body, so the axial, sagittal, coronal plans doesn't go with the heart. The heart has its own axes. We start with the normal axial MRI chest, through which a line through the left ventricle to obtain the two-chamber view of the heart, from which we have the short axis of the heart, which is the true axial of the heart, short axis showing the left ventricle and the right ventricle. Again, from the two-chamber view, we obtain the vertical long axis of the heart, four-chamber view, the right ventricle, left ventricle, right atrium, left atrium. Additional views needed according to each case: the LVOT, the left ventricle outflow tract, we hear the left ventricle, the outflow through the aorta, three-chamber view showing three chambers, left atrium, left ventricle, and the aorta, and RVOT, where we have the right atrium with the outflow tract, the pulmonary artery. Okay, when you start scanning, the heart is a moving structure in the surrounding lung, its respiration. It's a challenging technique. We have to use ECG gating, respiratory navigation, and breath hold. The patient have to help us with the breath hold. The standard sequences which are used are dark blood imaging, which show the morphology of the heart, the great vessels, and extracardiac structure. Then the bright blood imaging and the cine imaging, balanced SSFB, which is fast imaging technique, having serial of images acquired through different phases of the cardiac cycle. From these images, we obtain a moving and beating heart. This is the four-chamber view. We see the heart beating, we see the wall motion. If there is any wall motion abnormality, this is the short axis view. We assess the wall motion, we assess the flow through the valves. Any stenosis or regurgitation jet through the mitral, tricuspid, through aorta and pulmonary valves could be seen. We calculate the ventricular volumes, mass, systolic functions for both left ventricle and right ventricle. Then we have the T2 star images to detect any wall edema in cases of acute myocardial infarction or acute myocarditis. Then contrast injection. Upon contrast injection, we have dynamic images early phase, through which we can detect any perfusion defect, and then late gadolinium enhancing images. The dynamic images called the first pass perfusion. The blood, the contrast goes through the myocardium, enhancing the myocardium, and the hypoperfused myocardium appear as contrast against the enhancing myocardium. As here, the hypoperfused ischemic area appear hypoperfused and darker signal than the rest of the myocardium. And then we wait 10 to 15 minutes to obtain the late gadolinium enhancement images. These images are done after nulling the myocardium. The normal myocardium wash out the contrast, and we null the signal from it, so it appears dark. Only the scarred or infarcted myocardium or abnormal tissue will retain the contrast. The contrast stay in the abnormal tissue. So, and according to the distribution of this enhancement, we can define the pathology of this heart. For example, here it's subendocardial enhancement. It goes with ischemia, subendocardial transmural ischemic scar. A case of Hocum, here the enhancement is seen mid-myocardial and patchy. A case of amyloidosis, it's diffuse subendocardial. In case of myocarditis, it's mid-myocardial or epicardial. According to the distribution of this enhancement, we can define the pathology of these patients. After finishing the standard techniques, we have additional sequences which can be added and used according to each indication. First of all, the MR has had the unique feature of characterizing the tissue. It can characterize the tissue, the myocardial tissue. We have mapping techniques, T1, T2, and T2 star mapping. It's a substitute to the biopsy, substitute to the myocardial biopsy. T1 mapping, which can be used in cases of non-ischemic cardiomyopathies. This sequence, we can obtain the normal range of T1 value for this tissue. Any abnormal tissue in the myocardium raises the T1 value. Any edema or infarction, cardiomyopathy raises the T1 value. Difference from the T1 mapping and the enhancement. The late gadolinium enhancement, the scar is regional area which take the contrast. However, in cases of diffuse fibrosis and diffuse myocardial disease, infiltrative diseases, the lesion is throughout the myocardium. So it's difficult to detect it with late gadolinium enhancement only. We need more technique to detect the lesion which is diffusely in the myocardium. Here comes the role of the T1 mapping. First, we obtain native T1 maps, native maps before contrast, and through which we quantitatively measure the T1 value of the tissue. And then post-contrast, we have another map, T1 map post-contrast. From both maps, we obtain the extracellular volume map, here the extracellular volume map, which shows the remodeling of the tissue and the volume of the extracellular matrix in this tissue. The abnormal tissue, which is the infarcted or cardiomyopathy, has higher interstitial volume, so it has higher extracellular volume, and from this map we can detect it. For example, this is a normal patient with native T1 map and extracellular volume map, patient with amyloidosis, elevated T1 values, and elevated extracellular volume. So the T1 mapping help in early diagnosis of the pathologies and also in follow-up. T2 mapping can be used in case of ischemic heart diseases, in infarction, myocarditis, where it can detect the areas of edema and used in follow-up of the patient in these cases. There is the T2 star mapping, which are used in patients with hemochromatosis. There is this iron overload and deposition in the heart. It's a marker of this iron deposition and can be used in monitoring the patient with the chelation therapy. There is also the phase contrast imaging and 4D flow. Both Dr. Rana explained in details. They are used in many scenarios, especially in the congenital heart disease, where we can measure the blood flow velocity and assess the blood flow through the valves, detect any regurgitation or stenosis. The 4D flow, it's 3-directional velocity encoding, and can also measure the wall stress and the kinetic energy and also pressure gradient. The stress perfusion. The stress perfusion is used in patients with ischemic heart diseases. A patient with ischemia, we want to know the affected areas and the reserve in the coronary reserve in this patient. So we inject contrast. in the early dynamic phase, we inject a pharmacological stress agent like adenosine here in these patients. During stress, there is multiple areas hypoperfused. In the basal, it's inferior wall hypoperfused. In the mid, it is the inferior lateral. In the apical segment, there is inferior lateral wall hypoperfused. However, after rest, only this is hypoperfused in the basal inferior segment, so it is infarction, and the rest are ischemia, and in concluding the coronary reserve in this patient. Then we have the myocardial strain. The heart, when it contracts during the systole, it compromises different direction of contraction due to the complex orientation of the myocardicytes. First, there is longitudinal shortening, and there is circumferential shortening and radial thickening with torsion of the myocardium. So the longitudinal axis shorten and circumferential shorten with torsion of the myocardium and radial thickening. So the strain, it is the measurement of the deformation of this heart during contraction. The measurement, the lengthening, shortening, and thickening that happens. Okay, it is early detector of abnormal wall motion, of dysfunction, before even being evident as a reduced ejection fraction. So it's detect early contractile dysfunction and identify any regional myocardial impairment. Can be used in any of the cardiac diseases, as it's detect early affection of the myocardium before even the ejection fraction is affected. The strain, we measure the longitudinal strain and the circumferential strain and the radial strain through the cardiac cycle. We have the CMR tagging technique, which is a little bit longer because it needs a specific acquisition sequence with post-processing with lower temporal resolution. We apply these tags upon the heart during acquisition, and we follow these tags and see their deformation and fading of these tags to detect any abnormal deformation or abnormal contractility. The newer technique is the feature tracking technique, where the normal cine images, the normal cine sequences, 4-chamber and short axis are used in software, feature tracking software. We only identify the endocontour and the epicontour of the heart, and it measures the myocardial strain and form the myocardial strain curves. It's less time because we know we don't need extra acquisition time. It's no specific sequence needed. And easier than tagging. Take-home message: cardiovascular MR is an important tool in treating patients and decision-making. With rapid progress of MRI technology, many new methods are developed to diagnose cardiovascular disease. Cardiac MRI is tailored to each patient according to the clinical question. Thank you.
Thanks, Dr. Shaima. The last talk, fatal cardiac MRI starting